Up next, we have Professor Dr. Nikhil Munshi with a talk on how close we are to curing myeloma. We graciously invite Sir to take the stage and deliver his talk.
Well, so we are to the almost end of this very, very successful meeting with lots of good clinical care, science, and discussion of the disease management in light of the local access and local conditions. And so now for the final couple talks, I'm going to talk about more philosophical thing and where we are going, or more importantly, where we are. So these are my my disclosures. So when we're talking about cure, what is the definition of cure? And there are many definitions, and I will not go into detail. We can probably spend 1 hour talking about how do you call cure. But 50 plus years ago, there was an official definition, which was that after treatment, there would be a group of people who would not have any disease and whose eventual death rate of all causes would be similar to the general population. And then there was a revision to this official, made it simpler that it should be something that is not associated with any disease related illnesses or problems. And again, there are many nuances to it. And a simpler definition one of the patient gave was that cure is something where you grow old and die from something else. All means the same thing, that you won't die from the disease. And we all know that a lot of our patients do not die from myeloma, they die from something else. So when we look at cure and look at the survival curves, we should look at other diseases which we know are cured. DLBCL or Hodgkin's lymphoma, and you can see this beautiful line at the top. Even for CAR T, when you see DLBCL, post CAR T cell, 40% patients don't relapse after 2 years. In myeloma, the curves used to be are like this. Patients keep on relapsing even after years, and this particular study was 10-year follow-up, and we still see patients relapsing. So where are we now? Now, one of the older studies that I had a pleasure and privilege to be involved in was this total therapy program in Arkansas with my good friend and colleague Dr. Barlogi initiated. And if you look at the studies done there from total therapy 1 and 2, and then beyond my time there 2 and 3 actually, and there is a 4 and 5. But you could see that the survival curves are increasing, they're going up. And so with each addition of the drug, with thalidomide for total therapy 2, and then bortezomib and others with 3 and 4, the survival curves are improving. So we are definitely doing better. But the question would be, how do we cure any cancer, but in our case myeloma? So there are 3 or 4 things to look at, and one of the first principle is that the first shot we get would give us the best chance of a cure. More you allow patients to relapse, the chances of cures get less. And why is that? And it's because of many factors. And one of the factors is that as patients get more lines of treatment, their ability to get more lines or subsequent lines go down, and their improvement goes less. So if you take any study with first, second, third, fourth line, the PFS goes down, the response rate changes, and then not as many people get the treatment. And so then if you look at biologically why is the case, it's because how genomically the disease evolves. It starts with one cell, becomes 2, 4, and 6, and then starts with one mutation, which is a green cell, gets the red and the blue and yellow, and it's a mixture of those cells. So when we start treating, we may get rid of all the red cells, but the blue and green are still there, and they can grow. And the complexity of the genomic changes as it happens over time with all various clonal variants that come up, they may have all very distinct properties, or some of them have distinct property, and that makes the treatment more difficult. So when you, in the end, if you have 10,000 clones, we can eliminate 9,900, but there might be 100 clones that we cannot. Versus when that clonal architecture or complexity is only 1,000 cell, we can get rid of 999, and there are only few left that the body's immune system and other processes could take care of it. So one of the studies that was published, and again I think this was Dr. Boli's work, which was smoldering patient progressing to myeloma. So what changes genomically when this happens? And in this particular study, it was a smaller study, it was a 12 patient study, which showed that the complexity in smoldering is not very dissimilar than myeloma. There are still 7,000 mutations. It's very complex. But when we had sample from the same patient when it became myeloma, so they were paired sample, smoldering and myeloma, half of the patients had what in this Dirichlet curves you see, and I don't know how to show, yeah, there it is. So this is where, what it shows is that in this particular group of 5 patients, their genomic architecture did not change when they went from smoldering to myeloma. Versus this second group is where there was a new mutations acquired, number of them, before they became myeloma. And what it means is that these patients, these are the ones in the red here, their time to progression to myeloma was 7 months. So it's almost, they were already myeloma. We just didn't call them because they didn't have kidney failure or something. We were waiting for something to break before we call myeloma. The other group is where they required new mutations and new genomic changes before they became. And so as we wait, the complexity, as you see here, changes and increasing. And this clonal evolution and aggressive transformations are driven by many of the processes. And this is what some of it I described in the first place. And so we need to keep this in mind as we look for curative outcome in this patient population. This is one example where a patient started with smoldering with certain cytogenetic changes. At a newly diagnosed stage had acquired many more mutations and also many more copy number changes. And then at a relapse stage, it got even more complex. And so I'm sort of saying the same point with different examples, that we don't want to be in the last setting where it becomes more difficult to cure this patient. So when we look at complexity of the genome and the cure rate or even eventual outcome in this whole genome sequencing data, you could see that patients in the blue are with less number of mutation, in the red are more mutation. And there's a clear difference in the survival outcome. What it tells you again is the same point. More complex the genome, more difficult to get rid of the disease, and more quicker the time to relapse. And then, as I had mentioned earlier on the first day, there are many processes, and we and others are looking at all these various molecular processes which causes these mutations. And just to highlight the point how important it is to do the best treatment first, all these processes are active in myeloma and in many other cancers. And you can look at, and we have all sorts of assays that can measure this activity now, so that could also become clinically usable component to it in the long run. But using this in vitro assays, we have also inhibitors of this process, so we can prevent the genomic evolution, so to say. And all this together is providing and will provide ability to stop this progression, so then we can treat the disease without worrying about it. And this homologous recombination, and I'm going a little fast for a complex topic, but this homologous recombination is one of the primary means how myeloma cell acquires the genomic change. And so the green and black bar are myeloma cells, the red is normal cell. There is always a level of normal HR activity. Myeloma is significantly high. And what it does is that the blue bar in the middle are when the homologous recombination is high, and each blue bar just suggests a new mutation or new copy number change. You can see when you increase the HR, it significantly goes up. That's what happens in myeloma. And it leads to also development of drug resistance. In this particular study, what we did was we induced recombination, and then we were able to have the cells acquire dexamethasone resistance in a very short period of time. So these are the complex thing, and to even expand it to causation of cancer, when we increase the HR activity through this particular gene apex, we could induce chromosomal changes in the myeloma cells, or in normal cells in this case, which became malignant. They can develop tumor. And also we develop a fish model where by overexpressing this gene, fish develops tumors. Here it was expressed in the eye, so it had developed a type of retinoblastoma. And so point is that we want these processes to be controlled and treat the disease before all these complex changes happen, and that's a way to treat the disease best. So don't save the good treatment for later. Use it in the first shot. The second is that we need to get a deep response. So that's our second thing, need to attain the deep response. And we know the combination, 3-drug combination which are shown here, they give us very high response rate. And I think that is the starting point, and this is an old data, it's 2009. So this is what it used to be, already used to be 12, 15 years ago. Now we have done many other treatments and investigation, and I kept this old slide, I didn't change it for a deliberate purpose. So here in the 4th or the 5th bullet you see that single agent response rates diminish with increasing lengths of therapy, it's more refractoriness. Attaining a 20% response rate in 2020 isn't easy, so I must have given the talk in 2020 on this topic. And I kept this because how wrong that statement is. So in 2020, beginning of 2020, getting 20% response rate with a single new drug was not very easy, and then there are triple and penta-refractory disease, terrible. What has changed is what has happened in myeloma in last few years. What you see here is that in 2 decades, little less, 2003 was the bortezomib approval, so 20 years, 2 decades, we have 17 new drugs approved for myeloma. Almost 1 new drug per year. It's incredible compared to any other cancer. This is the best. If you look at the new drug approval over time, since 2001, in the first decade, there were 4 new drugs. In the second decade, there are 9 new drugs. And if you look at the third decade, 21 to 30, there are already 4 drugs approved. And if you plot the curve based on what we see here, we are in line to get 15 more new drugs in this decade. So if we think it is complex today, it's going to be incredibly complex in next decade or so. And that's a challenge, that's excitement. And to make the point that how wrong that statement was just 3 years ago, the first 7 drugs were approved with a median response of around 20 to 30%. They were approved for commercial use, and then combination give high response rate. If you look at the last 3 drugs, they are all approved with 60 to 90% or 95% response rate. So the field has changed incredibly, even in 2 years, with all these high response rates. And then if you look at how many in the United States, there are 5 drugs which are approved for 5th line treatment. Hopefully all them are coming in earlier line. PFS more than 6 years, OS more than 10 years. So again, we are doing better, but that's not my talk about, is not our doing better. Talk is, are we curing these people? So we need to go a little bit beyond just being happy with 10 plus years of survival. So we need to get deep response to get all this improvement. And the reason deep response is important is what we have seen in this meeting yesterday about MRD negativity. If there is a persistent myeloma, MRD positive, even though CR means myeloma cells are still there, that's not going to be an easy cure. So we need to get to where myeloma cells, at least by the current technology, is 0. And that will probably lead us to a probable curative outcome. So 10 to minus 5 is good, 6 is better. If we could measure, technically possible or physically possible, 7 would be even better. And then we include PET CT and other measure. But we have to try and get as deep a response as possible, and then reach where either time to progression of few cells is less, or the immune system takes care of this. And you have seen this data, and which is very exciting, and I might come to this slide again, is that now if you look at patients who are MRD negative, and these are, the top one is newly diagnosed transplant eligible patient, where we started doing MRD in the beginning, 10 to 15 years ago. So those are the patients who have had at least 10 to 15 years of follow-up, and you could see that in the end, the curve has a plateau, not many relapses. There's a large number of patients, 4,000, but we are beginning to see some straight line, or at least we can imagine a straight line. Again, as I said previously, this relapse patient population, although follow-up is much shorter than transplant eligible patient. That also is an exciting beginning. So I think deeper responses are great. But if you look at how much deeper we can get and how many patients, the CAR T cell are really illustrative that this is 6-line treatment. We get 98% response rate, 80+% CR rate, more than half patients getting MRD negativity, and then now you look at the survival curves, the PFS here in subgroup of patient population. Sorry, it has shifted, but what it shows is that patients who have more than 12 months of sustained MRD negativity, their relapse rates have gone down significantly. Just first 2 years of follow-up, these are all very new studies, but it is significantly increasing. And similarly, if you look at same patient population, even for overall survival, lots of patients are following without having any overall survival related events. And so incredibly deep responses, and some of them seems to be maintained. We need to have 3 to 5 more years to be able to say that these patients are probably not going to relapse. The third point is for cure is should the cure mean that patient is not on any treatment? And the standard pitch we all have for our patients, and patients complain, I'm taking all these drugs, when can I stop? And there are no side effects. And so the point is, just because it's a cancer drug, they want to stop it. If it's diabetes, they have no problem taking metformin or insulin, even which is injection. But lenalidomide, it's an easy drug. If it is not toxic for the patient, they want to get off. So should they get off treatment or not? In my mind, if they are on treatment, I don't think it matters, as long as they have a normal quality of life. They can take one Revlimid and live for next 50 years. I think we don't mind. So I think, should they be on treatment or not? My guess is that a lot of patients will require treatment for a certain period of time till we define that how much sustained MRD negativity is curative and we can stop. So for that, we'll need longer follow-up. But you could see that as we continue the treatment, and this there's a bar at the top, there are different controls, then thalidomide group, proteasome inhibitor group, len stopped early, and then the last one, len continued at PDE, and you can see they have a more sustained responses, etc., and they remain in PFS a larger proportion. And so I think this is an important, that probably we will need to have some treatment for current purpose. And if you look at this meta-analysis that looked at maintenance less than 2 years versus more than 2 years, 2 of the EMN study combination, clearly see that those who continued, the blue bar, are doing better than the yellow bar. So our expectations should be myeloma doesn't come back, but they may need something to maintain it, at least for a certain period of time. And then immunotherapy, I won't go into all of it. Nupur described beautifully all various things we are doing, both active and passive immunotherapy. The active one could be less toxic and can be utilized, which includes IMIDs as well in the active part, includes vaccination. Some of them are there, but not yet where clinically it can be utilized. But the passive one, the antibody-based treatment and the CAR T cells and the bispecific are the most important one for sustained remission to keep the disease in control. So that's the third bullet. And the fourth bullet is, should the cure mean that there is total disappearance of all the clones, or can an indolent MGUS clone persist? And that's an open for discussion as well. If we can confirm that this patient really has an MGUS, then I guess we may not mind if it stays for 20 years. But there is no way to be sure what is there is MGUS. And in absence of that, I would submit that we should try and get rid of the clone if we can. And so that is the important point to keep in mind. So now the question is myeloma curable with all the things we have and all the things we are doing? Or the alternate question is, are we curing myeloma? So again, back to the same thing, I would think that the straight line at the end in some of this data, 4,000 plus, and this is overall survival, suggests that patients are not dying beyond certain years. And that is very, very encouraging. I'm still not saying cure, which I might say in the end, but I think that's very encouraging. So we have to look at all different data sets. This is another older data set, and you can begin to look at the curve for PFS. One is a Pathema study, other one the Italian study, that between 25 to 35% patients have a beginning to have a plateau, and we can imagine and use a creative imagination, and we begin to see that certain proportion of patients are not relapsing within 10 years. So these both studies have over 10 years of follow-up. So sustained CR, now hopefully sustained MRD for 10 years, what would it be? So why are we not calling this cure? There was also a study done, it was a study done by the Arkansas group to looking for cure fraction from all various data set. And what it said is that even if you look at the old data set, proportion of patients who are meeting or exceeding the predicted remaining years of life is around 15 years. And that almost for 70-year-old is within the range of where they might die from something else and not from myeloma. So all very positive news about cure in myeloma. So where are we in regards to cure in myeloma currently? And these are the curves for ALL. That from 1950, there was a clear plateau. So in ALL, we didn't have to imagine. 50, 60, 70, 80, the curves have gone up. The curves are not too dissimilar in some ways to what I showed you, the total therapy data. We are right now 15 to 20%, where the curves are sort of staying steady. And we have to believe that these are old patients. So at some point they are dying and not from myeloma. So we have to have myeloma-related death studies to be sure what's happening there. So then with all this data, why am I not, me or you or everyone, not calling it a cure? So there are three cases here, and I'm going to ask you this question. So let's go to the first question. And I want you to say, do you think this patient is cured or not? So a man received chemotherapy for testicular seminoma 20 years ago and is NED since. Do you think the patient is cured or not? Does anybody think is not cured? Okay. So in the analysis, 92.9% patients, this was a large study done by Brigham and Women, our hospital, in a community oncologist. So these questions were asked to oncologists, not to general internist. And there were still 7% patient after 20 years of NED seminoma said he's not cured. Okay. Second case, a woman treated with CHOP for DLBCL 20 years ago and is NED since. How many think this lady is not cured? So in the study, 83% said cured, 17% said they don't think this person is yet cured. Okay. Third example, a woman treated for a stage 1 ER positive ductal carcinoma 20 years ago. When she was 47-year-old, she received adjuvant 4 cycles of FSE, cytoxan adriamycin, and then 5 years of tamoxifen, and she has been NED since. Stage 1 disease, ER positive. How many think that this lady is not cured 20 years later? No recurrence so far. Okay. So, 47. More than half thought that this lady is still not cured. So what does this tell us? This tells us that as an oncologist, we are skeptic and that we are not bold enough. And myeloma people, all of us included, are even more shy of calling a cure. And I think that's what we need to overcome, because we have good data to show that certain proportion of patients are cured. So we are optimists, but we are too cautious. Even one late relapse after 20 years, and I had seminoma in my previous life, I used to work on testicular cancer. If somebody relapses after 10 years with seminoma, that happens. But that doesn't mean the rest 99 are not cured. So we have to come out of that one example. So what I would submit to you that it is not only curable, myeloma, but I think we are curing a certain proportion of patients. We don't have good markers to say who they are yet. We have some ideas, but those patients live their normal life with or without maintenance, and they eventually die from other causes. And so task for us today is to increase that proportion from 15 to 20 to 50%, and with all the good things we heard in this meeting, I think we're going to be there. So thank you very much.
So Very fascinating, very, very fascinating talk. One of the thing, with the recent developments which have been taking place, do you think in future there would be a time and which you can put a category in your curable this thing is to little bit extend the definition of MGUS to include some SMM, and rest of the SMM actually goes to myeloma, and we take away the total category of SMM, so that somebody who is MGUS, he will remain as MGUS, like showed, and SMM already acquired, and we treat them. Now we have so many tools. This definition of high risk SMM, low risk, and with different definition, it creates so much of confusion among the residents. I'm sure that probably that you think would come a time in future.
Absolutely, you spoke my mind. I think there will be a time where I would say SMM is dead. Either it becomes my MGUS or we treat it as myeloma. Right now, ultra high risk, super ultra high risk, etc. And we are beginning to treat them like myeloma. Why not call it a myeloma? So the way we started with the definition, and no disrespect to all my senior colleagues who came up with it, we are stuck with this right now. Time will come when this spectrum, the continuous variable, will change to dichotomize two groups based on whatever features that will happen more clearly if we know we are curing it. So if we can cure myeloma, we can cure SMM as well. Right now we don't do as much, and then we are not sure. If you look at all SMM results, none of them are yet cured. So we want to cure them, but that's not where we are. So I totally agree with you. Okay. So thank you very much.
Thank you, Dr. Nikhil. Our last talk for the day is by Dr. Shaji Kumar, sharing with us his thoughts on fulfilling the unmet needs in the management of myeloma. We cordially invite Dr. Shaji to the dais.
I guess it's good afternoon, and thank you for staying till the last bit of the conference. And I just want to again reiterate my thanks and congratulations to Hari, Uday, and Pankaj for this wonderful meeting. It's a challenging task for me to come after Nikhil and all the wisdom that he's imparted in the past 20 minutes. What I'm going to try and do is kind of build on to what Nikhil just talked about in terms of the concept of cure in myeloma, and what are the unmet needs and what do we need to focus our future research on in order to get there. These are my disclosures. So I think when you think about the how we want to address, again, this is not just myeloma but all plasma cell disorders, but I'm thinking about the spectrum of MGUS, smoldering, and active myeloma for the purpose of this discussion. So first question is, can we prevent myeloma? And if you prevent myeloma, again, are we talking about primary prevention, that we actually prevent a monoclonal gammopathy from ever happening, or is it a secondary prevention where we actually going to prevent the MGUS from moving into myeloma? The second question is, if we cannot prevent myeloma, can we cure myeloma? And I think, again, Dr. Munshi nicely went through that whole concept, and I will limit my discussion on that part. And finally, if we cannot cure myeloma, let's say there's going to be a proportion of patients where we are not going to be able to cure this, can we control the disease and make it into a chronic disease? So I think that in order to reach there, we have to achieve other things as well. First of all, we need to understand the etiology of the disease, and I would say this is one part where the biology or the progress in terms of understanding the biology has been relatively limited in terms of all the studies done. We need to understand the mechanisms of disease evolution, and I think we have made significant progress, as you heard in the past day and a half, in terms of the genomic changes as well as changes in the microenvironment. Now, in terms of curing myeloma, we certainly need to, as was very nicely outlined by Dr. Munshi, we need to first understand, how do we define cure, and also understanding what is the changes or alterations in the tumor microenvironment that defines cure in this disease. And finally, if we cannot cure the disease and make it into chronic, disease, then we need to understand the mechanisms of disease relapse and drug resistance. So we already talked about this in great detail in the past day and a half about the spectrum of monoclonal gammopathies going from MGUS to smoldering to active myeloma, and how this is associated with increasing disease burden. Now we know that MGUS starts early and it evolves over a long period of time, and we know there are certain risk factors that have been identified. There's clearly genetic risk factors as exemplified by the increased risk in the Africans, people of African ancestry, as well as the familial increased risk. We also know there are environmental factors because of the increased risk amongst individuals exposed to pesticides and radiation. Now the question is, can we actually predict who is going to develop MGUS even before the MGUS happens? And these are studies that were done, so a relatively small study where we are able to show that individuals with polyclonal elevation of light chains actually have a higher risk of subsequently developing monoclonal gammopathy. Now obviously there are a lot of factors that could have driven this, including chronic infections. So we, clearly a lot more that needs to be understood. But if you were to actually try and prevent MGUS from happening, we really need to be able to understand who is going to develop MGUS. So that is really going to be, I think the really long or short here, because we have barely started scratching the surface of what actually causes monoclonal gammopathies. And we clearly need better estimates of the prevalence and incidence, and also the timing of the initiation events. And we have very little knowledge in terms of the MGUS in the early years. We have a lot of data looking at once it's happened in the older patient population. We have very little in terms of studies in terms of when the MGUS is actually starting to happen. And that is primarily because of the very early age of onset, and the fact that by the time you diagnose this at age 50, a lot of those studies have inherent recall bias to understand what would have happened 30 years ago. And at the end of the day, many of the strategies that we may have to prevent MGUS may not have a favorable risk-benefit ratio. But something that is probably a little bit more reachable in the next decade or so could be to try and prevent the progression from MGUS or smoldering to active myeloma. So there are three important questions in order to try and make that happen. One is, we need to know who has it, so that we need to identify them through screening. We need to know who will progress once they have it, and that is where the risk stratification models come in. And we also need to define if you're going to try and prevent the progression, what kind of treatment approach do we use, what is the right time to intervene, and again, are we trying to eradicate the clone, or are we trying to just delay the progression to active myeloma? We know that we don't recognize or identify the vast majority of people with monoclonal gammopathies, as has been shown in some of the epidemiological studies. And in fact, when you look at the recent ISTOP-MM study, you can see again, the proportion of patients with monoclonal gammopathies from the Icelandic study was clearly more than what we had anticipated based on the previous epidemiological studies. But they're also asking a very, very important question, which is, you don't want to screen for a disease and identify it if you cannot do anything about it. And that only will contribute to patient anxiety. So the ISTOP-MM study is going to answer a very fundamental question as to, if you screen, are we going to be able to make a difference? They have three different arms where we just do no further workup, you actually do more intensive workup, or you do more intensive follow-up. And what they have already shown is that we can certainly identify a lot more patients with something that's more beyond MGUS by doing this more intensive approaches. The question is whether that's going to actually translate to a better survival in the longer term. Clearly, having more sensitive techniques like mass spectrometry, we talked about quite a bit, we can identify more and more people with underlying monoclonal gammopathies and probably identify them early on. Whether that again will translate to a better outcomes for these patients, it's unknown, but one thing is clear: if we can identify these people early on, let's say in the 20s, in the second or third decade of life, by using mass spec type approaches, I think we are going to get to understanding the etiology of these conditions in these people. So could the future state be look like something like this, that you do a extremely sensitive mass spec based assay at the age of 50, and if you are negative,